Good morning, all. At the outset, I would like to thank Dr. Mansi Sabu and DiaObecon for inviting me and to discuss about the empagliflozin importance in the diabetic patient with CKD or across all the SGLT2 groups. So my talk is 5 questions and answers for CKD in type 2 diabetes, learning from the EMPA kidney trial. So my talk will be it is whether is it essential to access the albuminuria as well as GFR in all settings? What are the possible trajectories and implications of kidney function decline in type 2 diabetes? What is the optimum point of intervention with SGLT2 inhibitors in the progressive course of CKD so that we can delay the dialysis and end-stage kidney disease? And how should stewardship to be optimized for SGLT2 use in the DKD? And how have we guidelines evolved over the recommendation in clinical adaptation? So my first talk. So we all know that albuminuria as well as the eGFR both are important in diabetic patient to and this both data predicts the death very precisely, especially in the case of diabetes and across all the special cardiovascular events. Here, if patient with diabetes or without comorbidities, albuminuria and GFR are very significant markers for the predicting the death in type 2 diabetes patient. This roadmap data show that worsening of GFR as well as albumin levels as it increases from GFR decreases from 120 to 15 or albumin increases from 20 to more than 1 gram. There is a progressive worsening of kidney disease as well as the cardiorenal outcomes and hospitalization deaths are increasing. So same data are showing across all the groups. Yes, we know how to define the CKD. So CKD takes two things. One is the GFR category and second is the albuminuria category. And based on this, we can put this on this graph. And this is a beautiful graph which will lead you to know the patient risk. If patient falls in the green group, there will be lesser risk. In yellow, there is a moderate risk. Then red and orange, there is a very high risk of progression to the CKD as well as the mortality. And how we can define the CKD? If any patient is having less than 60 GFR with other markers of kidney damage, albuminuria, albumin sediment, urine sediment abnormalities, electrolyte abnormalities due to tubular disorders, or anomalies from the histopathology, any imaging problem, or kidney damage, these all are called the CKD. If patient is having more than 60 GFR with no other sign of renal damage, they are not CKD. So what they recommend, our AD and KDIGO consensus statements regarding the CKD screening in diagnosis of people with diabetes. If any patient with the type 1 diabetes, after 5 years of diagnosis, we should evaluate for the kidney involvement in form of best is the GFR with the CKD formula and measurement of spot urine albumin creatinine ratio. And if results are positive, then again we should not label it. We should rule out any transient causes which can cause this, right? Acute kidney injuries, stress-induced proteinuria, obesity-induced certain things. If this abnormality is persistent for more than 3 months, then they define the CKD. And what is the clinical importance? If we find it is a CKD, then we can start evidence-based of medicines like angiotensin receptor blocker, SGLT2s or pindrenone. And how to screen it is albumin creatinine ratio and GFR. And what defines kidney we all know. CKD. So again here that ESC 22 the guidelines for the management of cardiovascular disease in patients with diabetes, especially in low resources setting. So India is nowadays not probably low resources setting. All the patients should be measured USCR as well as the eGFR by CKD formula, and not very difficult. Or if it is a patient is very in remote area, it is not possible to find anything, then at least eGFR by the CKD formula is indicated to define the CKD staging. I will discuss one prototype 50 years old male patient with known case of diabetes since only 1 year. He has been hypertensive and dyslipidemic for 10 years. No major complaints except some instance of occasional high blood pressure. BMI is 30 kg, 30 kg per meter square, blood pressure 149 by 90, 140 by 90, hemoglobin 11, HbA1c 7.9 with fasting 145 and ppbs 220. Lipid profile was slightly abnormal with LDL 102. Albumin creatine ratio is 90, so it's a microalbuminuria. Creatine 1.5, GFR is 56. And ECG also showing myocardial ischemic changes. And he is currently on metformin plus anti-aversive telmisartan, amlodipine, hydrochlorothiazide, atorvastatin in the tolerated doses. So this typical patient is in our CKD group 3 G3A2. So it's a moderate risk for progression of the CKD and the cardiovascular complication. So my next talk, what are the possible trajectories in type 2 diabetic patient and implication in the disrupting renal function? We have seen as a practitioner, we all nephrologists have seen that many of our patients develop, once they develop microalbuminuria protein, they deteriorate very fast. One group of patients, they remain very stable. So based on this, there are classical four trajectories are there. First trajectory is gradually increasing in the proteinuria, persistent albuminuria, and subsequent gradual progression of decrease in the GFR. Second group is once when we intervene or naturally albuminuria decreases to the normal range, and such patients live again longer, and kidney failure is questionable. If we give all the pillars of renal protection, probably they survive longer. Third group is very rapid decrease in the GFR without albuminuria. Here, nothing much we can do about this because they are phenotypically, genotypically, they are different people. And fourth one is a non-proteinuric CKD, which very slower decrease in the GFR. In all our practice, many patients here we are seeing that they don't progress for years together. They remain stable, and most likely they don't go for the dialysis also, and they may develop some kind of cardiac complication, other complication before they die. So we all know that diabetes is associated with a greater risk of rapid GFR decline in Indian patients. This is the well-known data where diabetes and diabetic duration was significantly impacted by lead to rapid reduction in the GFR. And again, when there is a rapid reduction in the GFR, there is a high risk of developing of macrovascular and renal events and mortality in type 2 diabetes. So here again, because of the patient, those who develop the substantial decrease in GFR, they have very high risk of developing cardiovascular issues. Compared to those patients having stable GFR decrease, also some patients who have increased in the GFR also, they were at less risk. Again, when there is a rapid GFR decline, it is associated with 3.2 more times of developing heart failure. Echo data, as we all know. Again, if we decrease the GFR by any means, suppose we decrease GFR by 0.69 ml per minute per year, then it leads to 15% slower risk of developing end kidney disease over the 3.5 years. So it's better if we do progress the CKD by available means. This is the standard. If you see the graph, first graph, orange line is practically normal. When the patient with CKD, they develop over the time the GFR decline, and ultimately they will lead to reaching end-stage renal disease. If we intervene with some medicines, first graph, blue graph is showing that we give the ARBs, then there will be lesser slower progression. If we added SGLT2, then further slower, and if we third pillar we add MRA, again there will be slower progression, and there will be some data says up to 25 or 70 years we can delay the initiation of the dialysis. Our fourth pillar also is there, GLP receptor agonist with the flow data. It also is very effective in the retarding the progression of the CKD. Again, at what time we should intervene, give the SGLT2 inhibitors in the progressive course of CKD in type 2 diabetes. For that, we have to see the data of EMPA-REG, EMPA-Kidney. So this was the major blockbuster trial, EMPA-REG, which was primary cardiovascular outcome trial, but it showed a dramatic reduction in the renal outcome. Incidence of worsening nephropathy was 39% reduced, progress into macroalbuminuria reduced by 38% again, and doubling of creatinine or starting of RRT was reduced by 46%. So this was, although primary CVOT trial, it suggested it is very important also giving the better product in the kidneys, and based on that, this came very important in the practice. Again, empagliflozin prevents a rapid decline and consistently across the baseline eGFR or albumin creatinine. So whether patient is having more than 90 GFR, less than 45 GFR, or albumin creatinine ratio normal to macro everywhere, SGLT2 improves the outcomes. Again, chances of patient is, going from prior microalbuminuria to normal albuminuria was around 43%. Similarly, patients having macroalbuminuria and regression to either normal or microalbuminuria was around 82%. So massive reduction in the outcomes. Again, this is a major cardiovascular outcome trials where additional CKD benefits were there, and we will discuss main about the EMPA-REG and DICLATIMI. Again, DICLATIMI, EMPA-REG was a blockbuster trial because it was done in the established CVD patients and is showed all across major CV deaths, cardiovascular to any cause, all cause of mortality, hospital and heart failure, and CKD benefits were there. In DICLATIMI, kidney was positively impacted, but some cardiovascular data were not so convincing. Again, this was a broad spectrum trial and it included broad spectrum of patients, not specific with established CVD cases. So, but again, it was very successful trial. Again, let's discuss about the EMPA kidney data. So, EMPA kidney is one of the largest and most inclusive compared to DAPA CKD. It is more inclusive SGLT2 inhibitor trial in CKD to date. And EMPA kidney has more than 6,500 patients, and while DAPA CKD around 4,000 patients were there. Here, it was again in the broad spectrum of kidney failure from stage A, GFR category up to 90, and albumin creatinine category less than 20 patients were taken, and they were followed for longer period. Again, if we compare the EMPA KD with DAPA CKD, if you see the first number, patients were more in the EMPA kidney compared to the DAPA CKD. Second, GFR was practically lower in the EMPA kidney patient compared to DAPA CKD, and the many more patients were non-diabetic. In EMPA kidney around DAPA CKD around 40-45% were non-diabetic, while EMPA kidney more than 55% were patients were non-diabetic. So, and again, broader spectrum albumin creatinine ratio, if USI less than 30 was more in EMPA kidney compared to the DAPA CKD. So, this group of patient reflects broader spectrum of our CKD patients, those who encounter in day-to-day clinical practice. Now see the data. Empagliflozin, when the outcome was there, is EMPA kidney outcomes were there. So primary renal outcomes like developing end-stage kidney disease, any end-stage kidney disease with CV death or end-stage kidney disease, any cause, all well practically around 20 to 30% were impacted. Here again, if patients are given empagliflozin, it slows the GFR decline by half in patients with CKD across all the GFR as well as the albumin creatinine ratio. Whether albumin creatinine ratio is less or more, GFR is early stage of advanced stage, it positively impacts the outcome. This is very important slide. If we give empagliflozin at early stage of CKD where GFR is 85 ml versus we give it at 30 ml, so we can delay the dialysis up to 26 years in the first category compared to 8 to 9 years in the last category, and probably we can prevent around 4,100 dialysis sessions if patients are taking drugs regularly. This is the final outcome of the long-term effects of empagliflozin in patients with the CKD. That around 26% reduction for the ESRD and 26.5% reduction for the cardiovascular death was out. All-cause mortality was not significantly impacted compared to DAPA CKD, but again we know that this was a broad spectrum trial with lots of early patients were taken. Now, what is the stewardship to optimize the SGLT2 inhibitors in CKD? The problem with all our SGLT2 and angiotensin receptor inhibitors or pindinone, these all drugs do initial dip in GFR. So when patients come to you and you prescribe this medicine, they initially develop the worsening of renal function, creatinine may increase. So sometimes patient may lose hope. Many patients develop UTI, many patients develop some acute kidney injury. So that this is the Achilles heel for the use of this drug. Again, what we have to do is when we can stop whenever there is emergency for some time, but again we have to restart it. So that's why the patient can continuously get the benefit. So this is the data. If we do give the SGLT2 inhibitors in diabetic patient, so initially there is a dip in the GFR, but over the 1 year there will be better preservation of GFR compared to the placebo. So we should encourage our patient whenever we start this molecules that you will take around 1 year to start developing the effect, and initially there will be the worsening of kidney function, but you need not to worry. SGLT2, we all notice SGLT2 inhibitors consistently improve the cardiac outcomes in spite of initial dip in GFR. So if in the above all the slide, if GFR decrease more than ratio is more than 2.7 versus more than 2.7, again everywhere outcomes are good if we continue the SGLT2 inhibitors. Again, empagliflozin reduce the fluid overload. So our CKD patient is very important. So when bioimpedance studies were done, and absolute fluid overloads were less in the EMPA group compared to the placebo. Next important, yeah, if our patients are already morbid, highly fragile group, we commonly used to avoid this group drug. But data are showing that if we treat every 1,000 patients for the empagliflozin for 1 year, there will be lesser events in the CKD progression, cardiovascular death, or all cause of hospitalization, and there is slight ketosis, fractures, and symptomatic dehydration will be there. But overall, risk versus benefit ratio are in favor of the giving SGLT2 inhibitors. Again, one important and welcome side effect is that it increases the hemoglobin level in our patient with the cardiovascular anemia. These are data from Emperor Preserved trial. And mechanism is simple. When we give gliflozolins, they will inhibit the oxygen inhibition of SGLT2 inhibitors. There will be more tubular load at the distal tubule with the enhanced sodium transport. This will lead to medullary hypoxia, and this will activate a nutritional deprivation sensor like AMPK and SITCR-T1, and this will lead to ultimately higher transcription of the HEP2 alpha gene, and this will simulate the erythropoiesis. Again, most worried thing about SGLT is the UTI or genital infection. So across all the cardiovascular outcome trials, as well as the specific renal trials, there will be higher incidence of genitourinary mycotic infection, but not UTI complicated. If you see the empiric outcome, around there will be control. 18% patient both have control and treatment as UTI. But genitourinary infection was 6.4% compared to 1.8 in the control group. Again, same data as with the credence, decletemy, veritas, code trial. Even if you see the DAPA CKD or EMPA kidney, again, the incidence of complicated UTI was not very bad. This is the must. So this is how we should access in the clinical situation. Whenever we start new SGLT2 inhibitors, one thing is very clear: asymptomatic bacteriuria or past history of GU infection is not a contraindication to start the SGLT2 inhibitors. When there is a recurrent GU infections, it should be evaluated for the cause, and SGLT2 can be safely started if underlying cause can be resolved. Counseling on the signs and symptoms of UTI and the importance of perineal hygiene should be explained, and we should identify the patient with high risk for gene infection for close monitoring, and optimize the glycemic control will reduce the risk of GU infection. Whenever they develop, patient develop the GU infection by taking the SGLT2, early recognition is very important. Routine discontinuation is done of not using the SGLT2 inhibitors. Once UTI resolves or mycotic infection improves, we should restart it and reassess and treat the risk factor. For many patients about diabetes have diabetic cystopathy, bladder issues, stricture urethra. So these things can be evaluated and can be cured. Most important is the restarting of the SGLT2 inhibitors after infections are cured, and aggressive monitoring. This is a meta-analysis of around 20,000 patients regarding the safety, and most data have proven that this is overall very safe molecule. These are the major side effects of SGLT2 inhibitors, like serious UTI, serious pyelonephritis, serious genital infection, serious AKI, severe hypoglycemia, ketoacidosis, serious volume depletion, bone fractures in lower. So, but overall, all the data have shown that there is not a significant compared to the placebo, and all this group of patients can be managed with astute clinical observation and nice clinical care. This is very important. 6-day rule. Whenever patient, all the three molecules, SGLT2 inhibitors, MRA, as well as the angiotensin receptor inhibitors, they reduce the glomerular pressure. So any additional insult which reduces the glomerular pressure, they will precipitate acute kidney injury very early. So whenever we give patient undergoing operative surgery, angioplasty, angiographies, or patient are on the fasting, so we should transiently withhold ACE inhibitors, ARB diuretics, SGLT2, metformin, amyloid, NSAID. So this will prevent the further AKI or kidney damage. What guidelines have sent? So our prototype case, we all know there is a patient is having CKD 3A3, and it was not taking SGLT2 inhibitors. So prudent will be to add the SGLT2 inhibitors in this patient and give him the benefit of the retarding the progression of the CKD. Now guidelines across our KDGO, UK Kidney Association, everywhere SGLT2s are now the mainstay of treatment of CKD with type 2 diabetes. Now if you see the CKD Kidney Association guidelines, people with type 2 diabetes have given, there are 4 broad categories where this class 1A evidence exists that if GFR is of 20 to 45, GFR more than 45 with albumin creatinine ratio more than 25, symptomatic heart failure is irrespective of ejection fraction or established coronary artery disease, where we should definitely give it a class 1 indication. If SGLT2 inhibitor, if we SGLT2 decline GFR more than 45 but albumin creatinine is less, still we can give. Patient without without diabetes also same guidelines, except there is a strong evidence 1B for the GFR 20 to 40 plus albumin creatinine ratio less than 25. So again, KDGO, same guidelines, all the patients with CKD with GFR more than 20, albumin creatinine ratio more than 20, and plus minus heart
Right,
failure.
I request you to just finish.
Okay, thank you.